Hello, hello, okay. Good morning. So we'll continue with the gross anatomy of the abdomen and pelvis. All right. Yesterday, I think you had a class on the urinary bladder. So you're already aware of some of the constituents, organs inside the pelvic region. Now, the pelvis, as the name itself suggests, it's a basin-shaped, constrained area where many important vital organs are housed. And in the women, in female patients, the ovaries are very important, particularly within the reproductive period of 15 to 45 years. But even before that and after that, the ovary can be a cause of concern, that is, premenstrual or before menarche and after menopause. So its location, its orientation, its relations, its supplies, the changes it can undergo, and the other things which it can impact are important to look at. Today's class, I'll try to finish histology also, so I'll go a little fast. Please keep up with me. Since you're already oriented to some extent, I'll expect that you have already looked at the previous topics and therefore will be oriented with what I'm showing you. So the female reproductive system, as you already know, consists of the ovaries, which are the gonads, which have its own ligaments, its supports, which stabilize it in its location at the lateral wall of the pelvis. It has tubes, two uterine tubes, left and right, which lead towards a central organ called the uterus, which is enclosed within a fold of peritoneum. Now, this is a peritoneum, and this is a posterior peritoneum. And between this point and this point, there is a double sheet 1 and 2, folded upon itself sheet, in which the uterus is enclosed, and that double sheet of peritoneum is called the broad ligament. Then the uterine contents are expelled into a cavity called the vagina, which is also the place from which external spermatozoa enter in to fertilize the ovum and to cause pregnancies within the uterus. So ova released from here via the fallopian tube into uterine cavity. Spermatozoa released into the vagina via the cervix and the os and into the cavity. We'll do uterus again later. But we need to know that this is a continuity of the internal genitalia with the external genitalia. So external genitalia outside this vagina will be lip-like structures called the labia minora and the labia majora, which will be there in the perineal region of the female. So all this together is equal to the female reproductive system. But today we are looking at the gonads, which are part of the female internal genitalia. You have to get familiar with this section. This is a sagittal section, midline section, dividing the body into left and right halves. And the internal genitalia will be mirror images of each other. So in this case, this is anterior, this is posterior. So you're looking at the right half of this woman's pelvis with the uterus in exact hemisection the entire tube and the entire ovary of the right side are visible to you. The left side is completely out, it's not there at all. Similarly, you're looking at a hemisection through the vaginal cavity. In front of that is the urinary bladder and the female urethra. In front of that is a pubic bone. Behind of it will be the rectum, right? And behind that would be the vertebral column. So you're looking at the sagittal section to give you an idea of how the ovary is positioned, where it is located, and how it is constitutes part of the female external genitalia. If you look at it from the anterior aspect, ignores the right side. If you look at it here, you see that the uterus has a fundus, a body, and a cervix, and it leads into a vagina. But from the uterus, a broad sheet of peritoneum moves or is extending towards the lateral pelvic wall, which is called the broad ligament. And this ligament, it reflects off the bladder onto the front of the uterus and then folds onto the back of the uterus. So between those two sheets, you have certain condensations which are called ligaments of the ovary, and it leads to this gonad, which is seen as a bump on the anterior side. It is actually attached to the posterior layer of the broad ligament, and you see the fallopian tube leading out and curving to lie the opening end lying very close to the ovary, as it is related to a small pocket-like recess on the lateral pelvic wall, from where it is suspended by another fold of peritoneum. So this is the look and the appearance of all the ovary and all its related structures when seen from the anterior perspective. When you look at it, this is a kind of an oblique view, as if you're looking into the pelvis from above and in front. So again, you have the pubic symphysis cut, and you have the right side ilium, ischium, pubis, but you have the entire sacrum. So the left side ilium, ischium, pubis are removed. If you remove this side of the bone, how you will look at it is, you'll see the entire bladder, which you saw in yesterday's class, right? With the urethra going through a pelvic diaphragm. And behind it, immediately you'll see this entire uterus, which is bending over and related to the superior and posterior surface of the bladder. And it is angled, the axis of the uterus is angled on the axis of the vagina. And that would be the exit point. So when you look at the ovary, you will see that from the side of the uterus is leading out a fallopian tube, and it is curving, and there is a ovary behind it. So the blue one is the ovary attached to the posterior surface of the uterus and the broad ligament, with the fallopian tube coming very close to it. So when you see it, it's covered. This is the fold of the broad ligament in which the fallopian tube is housed, and the ovary is going to be attached to its posterior layer. That's the appearance of it. This is also to show you how the vasculature is going in between the two sheets of the broad ligament towards the uterus, fallopian tube, and it will also go through the ovary like that. So you'll have a ovarian artery also, which will be reaching it like that, and an important structure called the ureter, which is related to the origin of the vessels which are coming to the ovary. And if you look at it here, you can see the separation because you separated it out, but otherwise these vessels and this ureter is so closely applied to the place where the ovary sits against the lateral pelvic wall. Just to show you the relations from an in situ perspective, and it is inside the body, because otherwise all the diagrams are how it is when it is outside the body. Now that same section above, this was a full uterus. We haven't sectioned it, we just removed the bone and looking at it from that side. Now if we do a hemisection through that, you see the bladder, urethra, you see the uterus, vagina, and you see that. Then obviously this side, this half has been removed, so you're only going to see the right side, fallopian tube and ovary, related to the mesovarium, which is the fold of peritoneum of the posterior layer of broad ligament to which it is attached, and the suspensory ligament of the ovary, which I said is the fold of parietal peritoneum, from which the ovary seems to be suspended and kept propped up in its position in the pelvis, and the relation to the ureter. Okay. So it's a pair of female reproductive glands situated in the lesser pelvis, attached to the posterior border, below and behind the uterine tube. They are oval in shape or almond shaped, 3 by 1.5 by 1 centimeter, very small organs. They are smooth and pinkish in color before puberty, and after puberty every month cycle ova will be released from the surface, and they become, because of repeated ovulation, wherever the release happens a scar develops on the surface. So the surface of the ovary gradually becomes pinkish gray and then almost grayish, and that surface of the ovary is not covered by peritoneum. Please remember, the mesovarium is going and suspending the ovary, but the apart from where the mesovarium is entering the ovary, the rest of the ovarian surface is open to the peritoneal cavity, and this oocyte is therefore expelled into the peritoneal cavity to be picked up by the fallopian tube. So the ovaries lie in the ovarian fossa below the pelvic rim. In nulliparous means women who have not yet given birth to children. Gravida means pregnancy. Para means having given birth. The pregnancy has proceeded up to some point, any point. Maybe a complete pregnancy, maybe a successful or an unsuccessful pregnancy, doesn't matter. But if it has ended in a birth of some sort, delivery of the products of conception, then it's called a para. So in women who have not had any babies, who have not had a successful completion of or successful outcome of the pregnancy, the ovarian fossa is the location of the ovaries after birth, from the little baby girl onwards. That is where they will be located. But once the uterus has expanded with the pregnancy, then the relationships of everything which is related to the uterus shifts. Everything grows a little bit out, and then once the uterus involutes back after the pregnancy is over, the ovary position also shifts with it. So they tend to end up being in a lower position in the rectouterine pouch, especially after repeated pregnancies. So the position always is as if it is in a young adult female in the reproductive cycle who is not yet become pregnant. That's how we describe it. So the axis of the ovary is actually vertical. So there is a tubal end related to the open end of the fallopian tube, the fimbriated end, which is directed towards the external iliac vein. And there is a uterine end, down and medial, which is directed towards the pelvic floor. It's not looking very vertical, but it is more or less vertical. So there is a uterine end and a tubal end, right? Upper pole and lower pole. If you see in a multipara after one or more deliveries, then it becomes more horizontally placed. So you have it's more like a medial end and a lateral end, right? This one you can call it the medial end, and this one you can call it the lateral end. But we always describe it in this position as upper pole and lower pole. So two poles, upper and lower, two borders, anterior, which is attached, there will be a border, this will be attached to the mesovarium. Here they're not showing any peritoneal folds, but it would have come like this and folded over like that, right? So the mesovarium is where the if you've removed the peritoneal folds, you'll see that the attachments are such that to the posterior surface of the fallopian tube will be attached this mesovarium double sheet, and the anterior border is the one which is attached to the mesovarium, and the posterior border is the one which will be free. Now this is anterior and this is posterior, so actually it looks like it should be here. Probably posterior you can say is this whole border which is on the other side of the mesovarium, and the two surfaces will be medial and lateral. Now you're looking at it from the lateral side, so behind the board will be the medial surface of the ovary. So the lateral surface contacts the parietal peritoneum in the ovarian fossa, and behind that there are extraperitoneal structures including ureter, internal iliac vessels, obturator vessels and nerve, and original uterine artery. All of these are very important. To get an idea of that, how it is positioned, this is a view into the pelvis, but this is a coronal section. So if you have cut the cadaver into an anterior half and a posterior half and remove the anterior half, you'd see that the vagina and the introitus and the whole pelvic diaphragm, etc., are in a particular plane. They are almost in the vertical plane. But the uterus is completely angled to it, and so is the rectum behind it. There's a good 45-degree angle when you're looking at this. Therefore, this didn't get cut in coronal section, and you're looking at its superior surface. And you see that you have the tubes going away from it and turning, curling posteriorly, and to the posterior surface of broad ligament is attached the mesovarium and the ovary on either side, right? And the fallopian tube curving over it. So this pocket here, where this ovary is sitting, is called the ovarian fossa, and it is related to the ureter and the external iliac vessels and the obturator nerve, which is not there in this picture. We'll look at it later. And there will be certain structures which are called ligaments, ovarian round ligament of uterus, ovarian ligament, suspensory ligament of ovary, which we can't see in this perspective. I wanted to show you this view because we don't have access to a cadaver now, but you must get an idea of how it looks. So the top of the uterus is actually facing anteriorly, and it's almost horizontally placed like that, and it bends on itself. There's an axis, and the cervix becomes more vertical and in line with the vagina. So in this perspective, we're basically seeing the lateral structures in the pelvic inlet, near the pelvic inlet, and the ovarian fossa is right next to it, very close to it, tucked in against the beginning of the lesser pelvis, just below the brim. So if you take it out of its in vivo state, then we see that from the uterus we have the same thing. When you pull that to the side, you see you're looking at it from the back. This is a posterior view, otherwise you don't get to see the ovaries. From the front you don't get to see the ovaries, you only get to see it from the back. And at the back you see that it is related. You can't see the mesovarium because it's attached to this posterior ligament. It is coming like a shelf like that. So only if you take a cut section you can see that from that sheet of broad ligament in which the uterine tube is suspended. This is the sheet and the uterine tube is suspended in it. From that sheet to this sheet there is a double fold which is called the mesovarium, in which some vessels etc. are coming in, vessels, nerves, lymphatics, and then the whole ovary is suspended from it. Now the covering is only till here, and from here onwards you have a bare or free surface of the ovary. This is not covered by peritoneum, which is why these ovarian follicles are able to rupture through and fall into the peritoneal cavity. So anything happening on the surface here will release or fall into the peritoneal cavity. So this is the way to visualize, to see how the tubes are related to the ovary and how its ligaments are related. So you have two folds, one called the suspensory ligament of the ovary, which is relating it or attaching it to the lateral wall, and then there is a ovarian ligament here, ovarian ligament, which is attaching it to the uterine wall, lateral uterine wall. So medially ovarian ligament and laterally suspensory ligament of the ovary. Now this same suspensory ligament, if you follow it, right, you see that it is got the ovarian artery and vein and everything, ovarian artery and vein related very closely to it, coming in from the lateral pelvic wall. Alright. So visceral relations are the upper pole is directed upwards, related to the tube, attachment of the fimbria of the tube and the suspensory ligament of the ovary, right? That's what we saw. Yes, this one, upper pole. And then lower pole below, related to ligament of the ovary, right? Ligament of the ovary or ovarian ligament is lower pole. Then anterior mesovarian bottom acts as a hilum and conveys the ovarian vessels and nerves. So you have this is the anterior border. This would therefore be the anterior border. Remember, you're looking at it from the back. So this is back and this is front, right? That becomes the anterior border. And posterior border is a free border which is exposed to the peritoneal cavity. So this border which you're looking at, the back border, is this one. This border is exposed. It's hanging free to the entire peritoneal cavity of the pelvis, the pelvic peritoneal cavity. The lateral surface is in the ovarian fossa lined by parietal peritoneum, and the medial surface is covered by the fallopian tubes, and the peritoneal recess between mesosalpinx and this surface is called the ovarian bursa. That, how do we see that? That we can only see in a perspective. Okay, between the mesosalpinx and the mesovarium, right, is the ovarian bursa. This space is the ovarian bursa. This pocket between this one and this one, this pocket is called the ovarian bursa, not the ovarian fossa. Ovarian fossa is this side, the side wall pocket, the side of the pelvis pocket in which the ovary is sitting. So please don't confuse the two. Even if you forget bursa, it's okay, but ovarian fossa is extremely important. So what we're seeing is a peritoneal, okay, this is just to show you what the mesovarium looks like. And there are some vestigial structures called the paroophoron and the epophoron, which you would have heard about in the development. So those structures will be seen as embedded within this mesovarium, small tubule-like or duct-like or little pocket-like structures. We won't go into that right now. This is just to show you that there is an anterior mesovarial margin and a posterior free margin, right? Then there's a medial surface and a lateral surface and pole, right? So this will be the superior pole and the inferior pole. We're calling it the vascular pole because most of the vessels seems to be entering into this side rather than to that side, and these vessels will be derived from the lateral pelvic wall. We will look at that in a minute. So when you do a cut section, the point to be seen here is the relationships or the structures related in the so-called ovarian fossa. So we are looking at the tube, the broad ligament, and this is the anterior layer and this is the posterior layer. So this is the front and this is the back. So anterior layer of broad ligament is continuous and smooth and going to lateral wall. Posterior layer of broad ligament is covering the fallopian tube, covering the side, little bit of the extending rather from the fallopian tube, and then coming to the ovary and suspending the ovary and then going back to the pelvic wall, right? The parietal peritoneum is lining the fossa. So this space where the ovary is against the parietal peritoneum is called the ovarian fossa. This space between tube and ovary is called the ovarian bursa. And this space has got so many important structures. Please pay attention here. You have the internal iliac vessels we saw in the diagram before. We have the ureter, we saw that in the diagram before. We have an obliterated umbilical artery, and through this double layer from the side is coming the ovarian artery, ovarian vein, the vascular pedicle, and including the nerve supplies are coming from there. So these relations of the ovary are important. It might come to you. This is a good diagram, a good angle to take. Not easy to see in a dissection or in a slice. So another way of drawing the ovarian fossa is like this, against the lateral pelvic wall. So the internal iliac artery, its obturator artery and superior vesical artery. So obturator artery is important, and also there will be obturator nerve. Remember, it supplies the medial side of the thigh. So an irritation of the ovarian fossa peritoneum can impact this obturator nerve, and therefore you can have referred pain to the medial side of the thigh. That's one of the things you need to remember in terms of relations of the ovary in the ovarian fossa, laterally in the ovarian fossa. Then you have the ureter of the same side, pretty closely related to the ovarian fossa. Alright. So the boundaries of this ovarian fossa, above and front, are the obliterated umbilical artery. I showed you. This one is supposed to be above and in front. Above is the external iliac vein, behind is the ureter and the internal iliac vessels, and lateral wall of floor is the parietal peritoneum and the obturator nerve and vessels which pass beneath it. That's the obturator nerve, the obturator vessels, obliterated umbilical artery which is connecting to the vesicle artery. This is the urinary bladder and ureter, right? Not uterus and fallopian tube. So if you're looking at urinary exact midline section, this ovary is tucked in laterally, it is deeply placed, and the structures which are related to it within the ovarian fossa are as noted. Okay, so we have the ureter and you have the obliterated umbilical artery, and you have the obturator artery, and you'll have the nerve, obturator nerve. Okay, important to remember this. Now this is a view where it's a horizontal section. So you can see the three muscles of the anterior abdominal wall, right? You can see the rectus sheath. So it's like you're taking a transverse section just above the pubis, right? So the bladder is in front, this is anterior, this is the vertebra in the back, it's posterior midline, anterior to posterior. And you're seeing urinary bladder, uterus within the sheet called the broad ligament. Wanted to visualize the broad ligament, otherwise it's difficult to understand. So you have a parietal peritoneum covering the whole outside wall of the pelvis, and from the parietal peritoneum is arising a double sheet, an apron of peritoneum, which this peritoneum goes, covers the back of the bladder, goes down and comes up again and covers the uterus, goes down again and goes off to the lateral pelvic wall as the uterosacral folds. And this whole rectum is behind it. It's retroperitoneum because it's completely not involved with the peritoneal covering at all. So remember, the point is to remember this, that you have the descending colon and then you have the sigmoid and then you have the rectum at the back. This is the ascending colon, you have the aorta, inferior vena cava, all these structures are at the back. Then the sheets which are suspending, which are relating the uterus to everything else around it, is the uterosacral folds, and there'll be folds underneath in the front also. But how the ovary is related is at the back, it's tucked in at the back between the uterus and the posterior pelvic peritoneum. But here it is close to the lateral pelvic wall. It is very close to the lateral pelvic wall, behind which, see this is the parietal peritoneum, and behind it is the vessels. Okay, this is also retroperitoneum, this is also retroperitoneum. Oh, no, wait, this is cecum and appendix, this is ascending colon, this becomes retroperitoneal, and these structures are outside of the peritoneal covering. So the supports of the ovary are this suspensory ligament or infundibulopelvic ligament, which is attached to upper part of lateral surface, which contains the ovarian vessels and nerves. So can we see that? You see some vessels coming in here, right? This is a fallopian tube. You see the vessels are coming in from the lateral wall. So suspensory ligament of ovary containing the ovarian vessels is, if you stretch it out, if you pull it away from the parietal peritoneum, you see the suspensory ligament of the ovary. As it joins the peritoneum, which covers the psoas major, passes superiorly over the external iliac vessels, genitofemoral nerve, and ureter. The ureter would be coming in from the kidney like this to go to the bladder. It will be coming like this to go to the bladder. So it will pass via this suspensory ligament of the ovary, close to the suspensory ligament. Then in the same superior view, I've removed the back part so there's no confusion. You see the other ligament. So we saw suspensory ligament containing the ovarian vessels. Then there is a ligament of the ovary which is attaching it to the cornu of the uterus itself. It is attaching the ovary medial pole to, or rather inferior pole towards the uterus. It is again a fold of peritoneum. Then you have a round ligament of uterus, the one I showed you in the previous picture, which is going away from the uterus and going to the external genitalia, which is corresponding to the gubernaculum testis in the male, but it doesn't do anything. It doesn't actually serve any purpose over here. It is supposed to be considered one of the supports of the uterus. And you have the broad ligament, that this whole fat-filled broad ligament, from the posterior sheet of which is suspended the mesovarium and the ovary itself. So all four of these are considered the ligaments of the ovary. The ovarian ligament, which attaches to the lateral angle of the uterus and lies in the posterior leaf, the broad ligament. The mesovarium, the short fold, which attaches it to the back and carries the blood vessels and nerves to the ovary itself. Very important. That's why mesovarium is the vascular pedicle. And uterine tube arches over the ovary and ascends in relation to its mesovarian border. So what are the arteries? The ovarian arteries, branches of abdominal aorta, are given off at the level L2, L3. So they pass through that lateral suspensory ligament, the mesosalpinx, mesovarium, and terminate by anastomosing with the main uterine artery. A branch from the uterine artery, which is a branch of internal ilia, also comes to the ovary. So the two separate supplies. The major one is ovarian artery. The veins are different. They're similar to testis. If you remember, the testis had a pampaniform plexus. So the veins of the ovary are also a pampaniform plexus, which are in the mesovarium and suspensory ligament. From them, two veins will constitute. All of them join up and form two veins which emerge and ascend along with the ovarian artery back towards the inferior vena cava. They form a single vein, a single ovarian vein, and they end in the inferior vena cava on the right side, but on the left renal vein on the left side, just like the testicular vein distribution. So the gonadal vessels were the same to begin with before they differentiated into testis and ovary. Once they differentiated under the influence of the Y chromosome and released testosterone and so on and so forth, they migrate differently. So both of them come down towards the pelvic brim. One of them goes out through the deep inguinal ring, superficial inguinal ring, into the developing scrotal sac of the male baby, male fetus. Whereas the other one in the female, the default, if there is no Y chromosome, is that it will go into the side, it will go deeper inferior into the pelvis and remain behind on the side wall, where the developing uterus and fallopian tube will come and relate to it after they are fully developed. You, I think, seen a little bit of that, but also you will do development of the genitourinary tract, where this differentiation will be made clear to you. But do remember, the gonad is exactly the same to begin with in development, and because they both are migrating, either the ovary or the testis, they drag their supplies with them. So they're starting at L2, L3 level of development, but they're coming deep down into the pelvis. So the course and the length of the gonadal vessels is long because they follow, or they are pulled along with the gonads migration as the development continues. So this is the rich vasculature of the uterus. It is an organ which has to house another life for a long period of time. So it is provided with a very rich vasculature. And the ovary also gets some benefit. All endocrine glands, you remember, have excellent blood supply. So what ovary has is an artery and a vein coming in from the side wall and supplying here. But basically what they do is the main ovarian artery, the termination of it is anastomosis with the ending of the uterine artery. And the ovarian branch is going to come into mesosalpinx, mesovarium, and it's going to penetrate and end in the ovary. The other branch it can get is from the internal iliac system, which gives a uterine artery, which gives a ascending branch of uterine artery, which is actually supplying this side to the uterus, but also gives a side going branch, which will go and support or supplement the supplies from the ovarian artery. So the main gonadal artery and another branch from the uterine, which is from the internal iliac system. The veins form a plexus, and then they form two veins. It's supposed to be two by the time it comes here, and then become a singular one and go back to L2, L3 level to end on the right side in inferior vena cava and the renal vein on the left side. Lymphatic drainage is important because the ovary has plenty of pathology, particularly tumor-like. We will learn that in pathology in detail. But the lymphatic drainage is back to L2, L3 level of para-aortic nodes situated near the origin of the renal arteries. A few vessels may follow the round ligament. There was a round ligament which goes towards the labia majora in the female. So that area of perineum drains to the inguinal nodes, which was there in the lower limb. There was superficial and deep inguinal nodes, remember? So those inguinal nodes will drain the perineal area both in the male and the female. So if a little bit of lymph generated from ovarian tissue can find its way to inguinal nodes via the round ligament, accompanying the round ligament of the uterus. So you have most of it is ovary. Most of it is going via the internal iliac system back to the para-aortic nodes, right? Actually, it sticks with the para-aortic system. It goes via the para-aortic system, which are on the lateral aspects of the aorta and near the origins of the vessels, renal, gonadal, ovarian in this case, right? But a little bit of it can go via out underneath the inguinal ligament and come to lie in the inguinal region. External iliac nodes can get involved only with body wall relations. You might have heard about it yesterday with the bladder, but external iliac don't get involved with ovary. Innervation. So why does the ovary need innervation? It's an endocrine organ and ovulation happens under hormonal control, but there will still be stretch and pain fibers. So the postganglionic sympathetic are derived from T10, T11, and the parasympathetic S2, S3 derived from the abdominal autonomic plexus. Sympathetic fibers are vasomotor and sensory to the organ. Parasympathetics are only vasodilators, so they don't come into play much. Vasomotor because they keep the tone of the ovarian vasculature alive and keep the whole organ alive. So that the vasomotor vasodilation is the sympathetic parasympathetic balance, which is there for all organs, all viscera, and that is important. That's going to the vasculature, not to the organ itself. Whereas the sensation from the organ or the gland is traveling via the sympathetics. So visceral afferents go to spinal segments T10, 11, and the pain is therefore referred to umbilicus. You remember the dermatomes? The umbilicus dermatome is T10. So a pain arising from ovary undergoing any difficulty, the patient will feel as a periumbilical pain, referred to that part of his her abdominal wall. Sometimes this can be intractable. If you have a stage 4 ovarian cancer, which is inoperable, firmly fixated to the pelvic wall, and metastasizing locally and involving the local nerves, and the patient will not be able. We cannot offer her surgery or any therapy, radiation, chemo, anything which will help her, because it's almost end stage. And a purpose then becomes not to cure, because it's incurable, but to alleviate, to improve the quality of life. Then we do pain ablation operations. We're not trying to remove the cancer, we are not trying to change the progress of the disease, we are only trying to make the patient comfortable. So we do a interruption of the pain fibers by cutting through the suspensory ligament, which contains these general visceral afferent fibers. That's why we need to know what does a suspensory ligament contain, what does ligament of ovary contain, what is where, and what are the other structures along with it. So you only cut the ligament and don't cut off the vasculature, which creates another problem. So that's why relations are so important. So the innovation is particularly to understand why referred pain comes towards the umbilical region. The other place the referred pain can go to is the obturator nerve territory, the medial side of the thigh, but that's only if the obturator nerve is irritated or stimulated because of the local pathology happening there. Not if it's a pure ovarian phenomenon, but if it's a ovarian fossa phenomenon. So you remember T10, that is the referred spinal segment. Now let's get quickly to histology. I'll have to run through. So the production of oocytes and the production of hormones is the function of the ovary, and the microstructure is on the surface. It has a layer called germinal epithelium, which is actually derived from the peritoneum. Till here, mesovarium is peritoneum, right? So from here onwards, there is a single layer of cuboidal cells on the outer surface of the ovary, which is called germinal epithelium, but this is a misnomer because it does not give rise to the germinating over the producing cells. It is just a single layered epithelium, derivative of the peritoneum. Then you have a tunica albuginea, just like you had in the testis, but it is a much thinner layer compared to testis. It is a connective tissue domain. Then you have an outer cortex and an inner medulla. The outer cortex contains the follicles at various stages of development, and the medulla is richly vascular connective tissue containing vessels, nerves, and lymphatics. So this diagram you must have seen 100 times, and in physiology also you must have learned it. Follicles will be of different types, sizes, and this is the course of the development of a follicle, what all can happen to it. From primary, it can become secondary, it can become tertiary Graafian follicle, it can release oocyte, after which the regression of the tissue happens. It becomes what is called a corpus luteum, after which it becomes a corpus albicans. We will look at each of those. So this is just to explain to you that on the surface you have a germinal epithelium, beneath that you have a tunica albuginea, then you have follicles, inside of which we will look at that in a little more detail. This light gray and this light gray is cortex, and then there is a core area inside the ovoid gland, which is called its medullary region. This is what the histology looks like. You can see the follicles are so tiny, and each one of them you can see one cell in the center surrounded by a layer of cells. a space, you can't see the layer yet. So these are the primordial and primary follicles, and they grow into bigger and bigger and bigger follicles, and they can get to be, one follicle can become so big, really so big, right? Now this area where there are no follicles and there are only blood vessels and connective tissue is called the medullary region, and from here to here, wherever there are follicles right up to the surface, is called the cortical region. So there are three stages of the ovarian follicles. The primordial, located at the periphery, tiny ones, primordial follicles. Single layer of squamous follicular cells surrounding the oocyte, bluish, and a single layer of flat cells. Then you get a primary follicle where the cells are becoming more cuboidal. Then you get a multilaminar primary follicle where you get 2 or 3 layers of cells with the ovum in the middle. And then you have the secondary follicle where inside this outer multi-layered covering you get some fluid filled spaces developing. And then you get the Graafian or mature follicle where that all this liquid and this liquid, 2-3 liquids, fuse up and form a single cavity which is called the antrum, filled with this liquor folliculi, and inside of that the ovum remains attached to one edge of this big follicle, and that area where it's attached is called the, that's there in the next, it's called the discus proligerus, and this surrounding layers of cells is called the cumulus oophorus. And the ovum is separated from all these surrounding cells by a very clear region. It looks like there's nothing in it. That's why it was called zona pellucida. So the development of that is happening from here itself, the zona pellucida, and the covering cells are called theca folliculi. Then you have ovum, zona pellucida, granulosa cells, and theca follicula. So inner cells become granulosa, outer become theca. The inner granulosa cells form a sheet-like structure by the time the whole follicle matures, which we can now call a membrana granulosa outside, right? So the inner granulosa is called theca interna and the outer is called theca externa. So you have the cumulus oophorus. Outside of that you have a membrana granulosa. Outside of that you have a theca interna. Outside of that you have a theca externa. Please remember, it's a connective tissue domain. It's not cellular. It is connective tissue fibers. Then this whole thing, with pressure from the fluid building up, at some point will burst and release its ovum with its bunch of cumulus oophorus, which is then called the corona radiata, because those cells are stuck on the outside the zona pellucida. They seem to be radiating from it. So that was a name that is given. So the oogenesis proceeds from primordial follicle through growing follicle to mature Graafian follicle, right? So the unilaminar stage, multilaminar stage, appearance of zona pellucida, stromal cells, interna, externa. In the antral follicle, there is a cavity filled with fluid, and this new names called cumulus oophorus and corona radiata. The mature Graafian follicle will look like this. When we are showing you a slide, we will always focus on a mature Graafian follicle because that structure is not available anywhere else. Now this you have done in embryology, so I'll jump through. This is what a panoramic view of an ovary will look like. At any given point in time, an ovary, an adult mature ovary, will show you follicles in different stages of development. Many will be in primordial and primary state, some will be in secondary state, developing with like this. Then they will become a tertiary state where the antrum is well formed, and then they'll become a mature tertiary, which is the Graafian follicle, which has all the parts. Then there may be some which did not develop to full size, which are called atretic follicles, and some which have already released, which will be forming a corpus luteum. They got a corpus luteum anywhere. We got a regressing corpus luteum. These are degenerating structures. So you have generating structures and then the degenerating structures all together at the same time in any one ovary. So we will, I'll jump through this just to show you the actual histology. So this is very high magnification. So the germinative epithelium, the tunica albuginea, as you can see, is not much, little bit of connective tissue. And in the ovarian stroma, you see the primordial follicles, the follicular single flat nuclei, those are the follicular cells around the ovum. Then you have the oocyte again, nucleus. So this has to be very large for you to be able to see, but this is the development of the follicles as we saw before. Right? This would be a primary follicle with a single cuboidal layer of epithelium. When you see it with a normal simple stain, this is at a smaller magnification, you're going to see the early primary follicles. This capital P is the early primary and the small p is the primordial follicles. Here the ovum is much better seen and you're seeing the single layered of dash-shaped nuclei, right? Beginning to become cuboidal. Here it is squamous looking and here it is cuboidal looking. That is the differentiation. To see how large the nucleus and the nucleolus is, that's very important. Large oocyte nuclei. The secondary follicle, on the other hand, you will see that outside the zona pellucida, which is a pinkish domain, you see the multi-layered epithelium. That's what makes it secondary. And then you see a basement membrane outside of that. So this is a painting. This is how you expect it to draw it. A primary follicle, a primordial follicle, primordial and primary follicle, and then a primary follicle advanced stage. The secondary, this you won't be able to see, but this is what it is supposed to look like. This is what you will be able to see, but not at such a high magnification, where you have a theca externa, you have the granulosa cells, you have the corona radiata, the cumulus oophoris. You should call it corona only after it is shed actually. The whole of it is cumulus oophoris before it is shed. And you can see the differentiation of the cellular region and the fibrous region. Alright. Once that is released, you will see some areas which are called the corpus luteum. Luteum means yellow, and yellow it is to the naked eye. If you see a cut section of an ovary, there'll be pinkish gray, and then there may be some little yellowish regions, and those would be the corpora lutea. Active one would be yellowish. If it has regressed, corpus luteum would be available for the 14 days of the secretory phase, secreting progesterone, waiting for a pregnancy to happen. But if that ovum which is shed does not get fertilized, then this corpus luteum of menstruation undergoes regression and becomes a completely amorphous structure after some time, like a little scar tissue inside the ovary stroma. So what has happened here is the empty space from where the ovum was released, a little bit of blood clot will form. Vessels would have broken, the capillaries would have broken, and it will form a blood clot. And outside of that, you'll have connective tissue with some blood vessels, and you'll have a new set of cells, larger, paler cells, which are now an endocrine functioning cell because of the progesterone production. So these are called the granulosa lutein cell, and outside of that they'll be contained by connective tissue. So those are the theca lutein cells. So the theca externa is connective tissue and the theca interna is theca lutein cells. And you'll have blood vessels vagera in the connective tissue, but you are not going to see it at such high power. This is just to explain to you what a corpus luteum looks like, right? There'll be connective tissue in the inside, granulosa lutein cells and theca lutein cells. The corpus luteum will consist of this kind of cells, big, large, pale cells. You remember that they are endocrine in function. A corpus albicans will be white, not luteum will be yellow, albicans will be white, where it is completely regressing because its function is over. The 14 days are over, pregnancy did not happen, and therefore that corpus luteum has completely regressed. The cells are also becoming distorted. They're not retaining their cellular shape, and they have become non-functional. Nothing happens. And see, they get the material moves in, collagen material moves in and makes it into just a little bit of a scar tissue. The outside ovarian stroma is live and vital. The inside is dying. It is becoming less cellular and more fibrous. So this is a correlation. When the follicle is maturing, this is what is happening in the uterus. So this I think you'll have learned enough number of times. I won't go into it.